Good evening, respected professor and my dear students. I welcome you to the 17th Miot session of AISA Online DNB academic activities. Today we have some four important theory questions. To start with, I invite Dr. Soundarya to go ahead with this and entropy. Over to Dr. Soundarya.
I think Abirami wants to present first. He is already on. Whoever is ready, you can go ahead. No problem.
Good evening, sir. My topic is meningocele. It is a primary neural tube defect. Definition: the congenital defect in vertebral arches with cystic dilatation of meninges and structural and functional abnormality of spinal cord. It is a progressive neurological disease. Meningocele congenital defect in vertebral arches with cystic dilatation of meninges, but not neural tissue involvement. The incidence is around 0.4 to 1 per 1,000 live births. Development of nervous system, it includes two stages, primary neurulation and secondary neurulation. Primary neurulation, neuroectoderm bends at the midline to form neural folds, which elevate and meet and fuse in midline to form neural tube. Cutaneous ectoderm fuses first to form overlying skin, followed by neuroectoderm. In neurulation, it involves formation of spinal cord distal to mid-sacral regions. Neural tube defects is basically due to interruption of migration of neural crest cells between 18 to 28 days of gestation. Primary neural tube defects include meningomyelocele, encephalocele, anencephaly.
Surgery for which?
Secondary neural tube defects include meningocele, sacral agenesis, dysgenesis, myelocystocele, that is diastometromyelia. Causes of meningomyelocele. It is most common in low socioeconomic status. Most common nutritional deficiency of folic acid in mother. Amniotic bands disrupts the normal neural tube formation. Chromosome and genetic causes include trisomy 13 and 18, and maternal medical conditions include diabetes, obese, infections, intrauterine drug exposures like valproate, carbamazepine, methotrexate. Diagnosis, usually intrauterine diagnosis includes imaging, fetal ultrasound at 18 weeks of gestation. In case of laboratory, increased maternal serum alpha-fetoprotein, increased amniotic fluid alpha-fetoprotein, acetylcholine esterase in amniotic fluid. After birth, usually MRI spine with the help of MRI spine. Clinical presentation, it may be asymptomatic with visible swelling over back. It includes progressive neurological deficits like paraplegia, seizures, cognitive defect. 20% it is associated with kyphoscoliosis, neurogenic bowel and bladder, pathological fractures, progressive bony spine and joint deformities. Associated anomalies, most commonly it is associated with hydrocephalus 80%, ulnar cherry malformations, craniofacial anomalies like receding mandible, trismus, seizures, Klippel-Feil syndromes. In case of airway, cleft lip and cleft palate, and in case of CVS, AD and VSD. Genitourinary includes extrophy of bladder, single kidney, hydroerythronephrosis, vesicoerythric reflex, and undescended testis. In case of GA, anorectal malformations, musculoskeletal seat like club feet is more common, scoliosis and hip dislocations. Immediate postpartum care include careful assessment in lateral prone position, avoid latex contact, and a lesion is covered by moist dressing or plastic wrap to prevent heat loss. Repair, meningomyelocele repair should be done as early as possible within 48 hours. Pre-op assessment, history like antenatal history of drug ingestion, similar defects in siblings, birth history like prolonged labor, delayed hypoxia, it may be due to hydrocephalus. Limb movements to rule out any neurological deficits. Examination, nutritional other deformity, airway assessment in case of facial cleft, ulnar cherry malformation. Back examination, we should inspect defect like size, shape, location, CSF leak, and curvature of the spine. Respiratory, like apneic episodes, any history of aspirations in case of ulnar cherry. Identify and rule out other associated anomalies like club feet, cardiomegaly, kidney enlargement, hip dislocation. Pre-op investigations include hemoglobin, platelet, WBC, which in case of infected sac and it increased in UTI. Serum creatinine and urine routine associated anomalies make patients susceptible to UTI. chest X-ray if symptomatic, or to rule out cardiomegaly. Blood grouping and cross-matching, CT brain or MRI in case of hydrocephalus. Pre-op optimization, we should get informed consent from mother. Standard starvation guidelines, and we should also compensate for CSF leak. Clear liquids for 2 hours, breast milk for 4 hours, solids and cow milk and formula feed for 6 hours. Anesthetic challenges include basically age, like neonatal age, airway difficulty in case of large head associated with facial cleft, and pediatric. Positioning, blood loss and fluid, hypothermia, and any latex allergy and coexisting disease. Introp consideration include patient optimal, presetting the optimal OT temperature to maintain normothermia. Positions, avoid physical trauma to lesions, and support part of back that are not involved. A rolled towel or place a lesion within the donut. Ring cushion of appropriate size, or in case of we can do in lateral position. Where monitoring includes ECG, saturation, NIBP, temperature, ADCO2, Harley urine output monitoring, glucose monitoring. 2 large IV cannulas considered in case of blood transfusion or volume resuscitation. Difficult airway card should be kept ready. Usually it is general anesthesia is preferred. Spinal anesthesia has been performed with hyperbaric tetracaine injection in neural tube defects. Supplemental dose may be required because the duration lasts for about only 90 minutes. Like induction usually inhalation induction with sevoflurane is preferred. IV induction can also be used. Thiopentone 3 to 5 mg per kg IV, or for 2 mg per kg IV. Muscle relaxant, opioids, fentanyl or revifentanil can be used. Muscle relaxant, atracurium if no neuromuscular monitoring. Succinyl chloride can be used, but it is contraindicated in case of CNS deficits. Then airway is secured with flexometallic tube, and anesthesia maintained with controlled ventilation, isoflurane or sevoflurane with air and oxygen, with a MAC of less than 1. Maintain normocapnia and normothermia. Intra-op neurophysiological monitoring is applied for complex cases, structures, and prevent damage during surgery. Motor work potential, somatosensory above potential, and electromyography can be used. In infants, neurostructures are not completely developed. This neurophysiology monitoring may be affected by anesthesia, hypotension, and temperature. Inhalationals usually suppress motor work potential and somatosensory above potential, but propofol and ketamine does not suppress. So we use modified anesthesia technique like TIBA, opioid-based anesthesia used with limited use of volatiles. If response is suppressed, check a rule out like hypothermia not recovered from initial neuromuscular blockers and large bolus of opioids. And then surgical positioning, usually prone position with a size and head well supported, padding of eyes, face, and pressurized points and bony prominence. Free abdomen movement, allow adequate access to IV lines and circuit placements. Then after surgery, reversal and recovery, extubation, prophylactic antiemetic, emetic 0.15 mg per kg 30 minutes before extubation. Neuromuscular blockade is completely reversed, and extubation is done when child is awake and breathing well. Post-operatively, they transported to neonatal ICU for close neurological monitoring and evaluation for CNS infection. Patient need to remain in the lateral or prone position to allow defect to heal. Post-op complications like airway obstruction, edema, laryngospasm, post-op apnea, delayed recovery, latex allergy will be there. In a prenatal surgical repair was also done around 23 to 25 weeks of gestation. Involves maternal laparotomy followed by uterotomy and externalization of fetus. It increases the incidence of maternal morbidity. It is usually done under GA with epidural placement for mother and intramuscular injection of fentanyl and meconium for fetus. That's it, sir.
Completed?
Yes, sir.
Very good. Very good. Are you a post-DA student or a primary student?
Primary student, sir.
Okay. Have you ever seen a case of meningocele in your career so far?
No, sir.
No. Okay. So even as a undergraduate, when you are pediatric postings, you never had a chance to see a case of meningocele, lumbar or sacral or cervical meningocele. I won't be surprised because it's such a rare case that it is not seen by students in their career, even sometimes when you until your retirement. In my career of 50 years, I have seen only two cases of meningocele, and I had to give anesthesia only for one case that because it was a neonatal emergency.
Okay, sir.
You made a very good description about the pathophysiology, how it is being just one second. இதை நான் கிளாஸ்ல இருக்கேன் ஒரு 8 மணிக்கு கூப்பிடுறியா? ஆமாமா. So what is the gestational time at which this problem will develop?
4 weeks, sir. 18 to 20.
Anything 4 to 8 weeks, the first trimester itself. Okay, that is the time when the neural tube defect, closure does not happen properly, and there will be a defect in that.
Yes, sir.
And this question of anesthesia for a lumbar or a cervical myelomeningocele or a simple meningocele, it can be a theory question when you appear for your theory exam. In the third paper, when they give the clinical scenario questions, it may appear as a theory question in your theory paper, or it may be kept as a short case. If such case is available at the time when you go for your practical exam, may be kept as a spotter or a short case for discussion in the viva and practical exams also, or they may give you a case scenario to test your knowledge about neonatal anesthesia or the pediatric anesthesia and give you the scenario and ask you to discuss about that.
Yes,
You have covered nicely almost all the points, but it may have to be regrouped or presented in a little more sequential order so that you will be able to write it in a better presentation will be appreciated well if you do it in a little more orderly fashion.
Yes, sir.
So first and foremost is when you must know the embryology or the developmental defect, how it is happening. You must always say at which gestational age this defect starts happening. And then mode of diagnosis, you mentioned it can be diagnosed nowadays antenatally by the
18
mother's
weeks.
uterine examination. Okay, when we do the anomaly scan, we can pick up all these problems in the fetus, and that time itself we can identify if it is quite a substantial bulge, which is the only condition which cannot be detected by ultrasound, the spinal defect. If there is no bulge, what is it called? There is a defect in the spina bifida occulta. Okay, so it may be spina bifida occulta, which is not usually easily detected, but all the other cases of bulging meningoceles will be easily detected, and it can be, as you said, treated intrauterine life itself. Nowadays we do intrauterine surgeries or what is called extreme surgeries.
Intrapartum treatment.
Intrapartum repairs of the defects are being done, but it's mostly for the airway defects and not this spinal defect.
Okay,
And once the baby is born, it is a congenital defect. So the baby is born with a congenital problem. The first and foremost thing that a pediatrician or a neonatologist will be checking is for any motor or sensory neural deficit in that patient. Okay, many meningoceles may not have any neural content in them. It will be only the dural bulging sac with a fluid of CSF, and that may not produce any neurological defect. Child may have a normal movement in the lower limbs, the limb flexion, extension, all will be normal. The response to pain will be normal. So in those cases, there is little time for us to do the repair. But as you rightly said, it should be repaired at the earliest, because what are the complications that can happen in this if you don't repair it?
Infection, wound infection.
First and foremost is the skin by rubbing, because it is on the back. You cannot put the baby on the back. So if you put it on, there will be pressure on the skin, and the skin will start getting eroded, and it will pick up an infection, and that may cause spread to the meninges, become meningitis, and then it may lead to a very serious neurological problem. The second thing is, once the skin gets breached, then CSF will start leaking. And what is the role of spinal CSF?
Push.
The exam, they may ask you all about CSF instead of asking about the neonate and the meningocele. So
Cushioning
in
and
practical exam, you should be ready to answer all neuro-related topics. So CSF, what is the function of CSF?
cushioning and balancing effect.
Cushioning, which one?
A brain.
What do you call that? What is the correct terminology that you should use instead of saying cushioning, which is a common man's term?
Buoyancy.
Buoyancy, buoyancy, buoyancy. Okay, so it makes the brain float so that it doesn't come and hit on the hard skull surface. So it gives that buoyancy and reduces the weight of the brain so that the chances of injury when turning the head is not there. So if CSF starts leaking from the vertebral column by a breach in the meningocele, what will happen? Which is supporting the brain, the meninges in the top, in the skull.
Yes, sir.
This is the spinal CSF. Even though the babies are lying down, the main support is coming from the spinal content of the CSF. Okay. So when there is a leak, there will be a sag on the weight will start pressing on that, and there is a chance of which part of the brain can herniate through the maximum opening in the skull.
Brainstem.
Brainstem. Very good. So that brainstem coning, it is called coning, can
Coning.
happen. Okay? So the CSF leak should not be allowed, and you must give prophylactic antibiotic right from day one once you diagnose it. That is a very important point which you have not mentioned in your answer. So even before you plan for surgery, child should be started on antibiotic cover so that we can prevent an infection happening. And if there is already an excoriation or a injury to the skin, then it should be covered with sterile gauzes and kept moist so that it doesn't harbor any infection there. These are the two preventive treatments that the pediatric surgeons or the neurosurgeons will do before the baby is brought to you. And the challenges of neonatal anesthesia, you just mentioned a few things, but for your further knowledge, what is the definition of a neonate? How do you define a neonate?
Within 24 hours. Birth after 24 hours.
Only 24 hours?
28 days.
28 days. So supposing a child is born at 36 weeks. So up to 37 weeks only is it the neonates?
Preterm.
Preterm. You say up to 28 weeks after birth, 28 days after birth is the neonatal period.
Yes, sir.
A child may be born at 36 weeks, another child may be born at 38 weeks, another child may be born at full term 40 weeks. Which one you will say? 37 weeks is neonate for 36 week
After
born
37
child?
weeks. After 37 weeks.
Who can tell me the correct answer for this? Soundarya? Are you there, Soundarya?
Yes, sir.
What is the definition of a neonate?
Post-conceptional.
Post gestational age of 44 weeks. Okay. It is up to 44 weeks of post conceptual or post gestational age. Okay. So if a child is born at 36 weeks for some reason, mother is having a preeclampsia and you want to deliver the baby. After 36 weeks, the pediatrician feels that baby is mature enough, you can deliver the baby. But even if it is delivered at 36 weeks, up to 44 weeks, that is another 5 weeks, it has to be called as a neonate only. Similarly, a child born at 38 weeks, up to 44 weeks, it has to be called as a neonate only. So any baby up to 44 weeks of post-gestational age is called the neonate, irrespective of the time of delivery, whether it is 36, 38 or 40, up to 44 weeks of post-gestational age, it's a neonate. So what are the challenges in the neonate? Most important challenges for anesthetist?
Airway.
Airway will be difficult. Okay, why airway is difficult?
There will be large head.
Huh.
Um,
Large head, then
a floppy epiglottis, omega shaped.
floppy epiglottis. Okay.
Larynx will be conical.
Larynx is
Conical in
situated
shape.
above at a higher level.
Like, C3,
Cephalad
C4.
movement. C3, C4 level.
And more anterior.
More anterior. The subglottic area is much narrower than the glottic entry. Okay. All these things make intubation and airway maintenance very challenging. Number one. And what about the various systems? Are they all fully developed at when the child is a neonate? Like your hepatic function, renal
So
function.
hepatic and renal will get matured after 1 year.
So even autonomic system, what is the difference in the autonomic function in a neonate compared to an older child?
Parasympathetic will be.
Parasympathetic is well developed compared to sympathetic. And when does the sympathetic become fully functional? At what age?
2 years.
After 3 months only, 3 to 6 months. Okay. Until then, the parasympathetic dominance will be there. So if you have a delay in intubation and the child becomes hypoxic, what will be the cardiac response to hypoxia in a neonate?
Bradycardia.
Bradycardia and arrest. Okay. Unlike an adult who can increase the heart rate to increase the oxygen supply, pediatric patients will usually have a bradycardia because the sympathetic overactivity will not happen when there is a hypoxia. Okay, that is a very important challenge which has to be taken care of. And the other important two things: can they withstand hypoglycemia?
No, sir.
Why? Why they are not able? Glycogen storage is very poor in them. Okay, because the liver is not functioning normally, their glycogen storages are very poor. So unless they get adequate glucose from exogenous sources, they tend to become hypoglycemic. What is the value for hypoglycemia in a neonate?
Less than 40.
Less than 40 milligrams. Very good. So unlike an adult, which you say less than 80 is hypoglycemia, children less than 40 is hypoglycemia. You should take care of the prevent this hypoglycemia. And the third important thing is the hypothermia. Why they are not able to maintain their body temperature at normal level? Why they become hypothermic faster?
The subcutaneous fat will be decreased and non-shivering thermogenesis.
What do you understand by this term non-shivering thermogenesis?
Like norepinephrine mediated vasoconstriction.
Norepinephrine mediated vasoconstriction.
Metabolism of heat.
Which fat? Is there a special fat in neonates and infants?
Brown fat.
Brown fat. Okay. The metabolism of brown fat only gives them the heat that is required. Where is this brown fat situated?
Nape of neck.
Neck. It's not inside the thoracic cavity. Is it so superficial? The nape of the neck. Nape of the neck means you can palpate the fat. Is it? It's so easily palpable, the brown fat? It is not. Okay, it is present in the thoracic cavity between the scapula. It is present in the suprarenal area. Okay, that is where the brown fat is situated. And this brown fat metabolism only supplies what is called the non-shivering thermogenesis. Because in older children and adults, once we drop our temperature, core temperature goes to less than 36, our body muscles will start getting contracted. They will start shivering to increase the heat production and bring back our body temperature. Because of the less small amount of muscle mass in the pediatric patients, they cannot shiver. They cannot increase the muscular activity to increase the power. So and what about their blood volume? What is the blood volume of a neonate?
90 ml per kg.
90 to 100 ml per kg. Okay. Will it increase or decrease as the child grows?
Decrease.
It will decrease. Okay. Adult we have only 70 ml per
25 ml
kg.
per kg.
Whereas the child has got, a neonate has got 90 to 100 ml per kg. And this small volume, if it is lost because of an extensive surgery, can the child compensate for that?
No, sir.
Why? An older child undergoing a surgery and a neonate undergoing the same surgery. Neonate loses 75 ml of blood. Older child also loses 75 ml of blood. What will happen to these two kids? Who will become hypotensive and hemodynamically unstable faster, and why?
Neonates will become unstable.
Why?
ECF.
Proportion of blood loss is much higher.
Okay, very good. And why they are not able to compensate for that? How does the older child withstand this 75 ml of blood loss? What should the heart do whenever you lose blood? What should your heart do?
Quick response, no vasoconstriction to raise the blood pressure.
Does the heart start functioning first, or the vascular system start reacting first for a hypovolemia?
Heart, sir, but they will know they cannot have tachycardia because
no, they will have in pediatric patients, the cardiac output is rate dependent. They cannot augment their stroke volume, but older patients, they can increase their stroke volume by more muscular contraction of the heart. Okay? They will increase the cardiac output both by increasing stroke volume and heart rate. Whereas in pediatric patients, especially in neonatal patients, the cardiac output is rate dependent. It has to increase the rate enormously to achieve the same cardiac output which is required, and they have very little muscle mass in their heart as a developing child, and that will get fatigued much faster, and cardiac function will fail very soon. Okay, that is the reason why in neonatal patients and in pediatric patients you should not allow too much of blood loss. So we have to calculate allowable estimated blood loss before surgery in neonates. That is a very important point from cardiovascular stages or the vascular system. So how do you calculate the amount of blood loss that you can allow to happen?
Estimated blood volume into initial hematocrit minus final hematocrit by initial hematocrit into 100.
Excellent. So that volume has to be calculated, and you must keep that replacement solutions or blood ready. Especially blood loss is to be replaced only with blood in neonates and children. Yeah? If you try to correct it with crystalloids like you do in older patients, they will get very much diluted. Hematocrit will become very low, and they will not have adequate oxygen carrying capacity. So the tissue will go in for lactic acidosis because of lack of oxygen, and patient will develop severe acidosis from which the cardiovascular system will irreparably fail. So that is the reason why you must always have adequate blood reserved for the surgery that is planned for the children. Okay? That is a very important point that we have to mention in neonatal. So these are all the questions expected from you to be answered in the Viva examination.
Yes,
and you have to make a mention of these things in your theory examination also. Okay.
Yes.
And then the next challenge for this particular thing has to be highlighted. So when you have a lumbar meningocele or a myelocele, you must make sure that the swelling is not under compression when you position the baby for your airway securement. So when you try to achieve, because you plan to do it under general anesthesia, you have to position the baby correctly. Already it is going to be a challenging airway, so you have to uh, make sure that position is optimal for you to intubate the child without any difficulty.
Yes, sir.
At the same time, you must make sure that the swelling is not under compression or is not being breached by the weight of the child itself. For that only you mentioned about the donut. You make a ring and then allow the baby, that portion of the body to be placed on that, so that the swelling will hang and will not touch the table. Okay, it will be elevated from that. And very severe or large cases, you can even do the intubation in the lateral position as we said. But usually lumbar and sacral meningoceles can be managed in this way. But if the swelling is in the cervical region, that is going to be a much more challenging thing.
Beyond
So
the
it's
edge
a
of the
question,
table.
you can drop the child beyond the edge of the table and have it in the, supported on the lap. Or what is the other safe option?
We must lift from the table and
No. If it is a cervical meningocele, preventing the extension of the head or the positioning the head properly for oral introduction of a laryngoscope and visualization and intubation, what is the next safe alternate for intubation of the child? Would you still like to go induce anesthesia and go ahead with your intubation, or is there an alternate modern gadget which you can use to intubate the child? Fiber optics? Have you heard of fiber optic intubations?
yes, sir.
So you can do a fiber optic intubation where you can keep the patient in any position and then try to secure the airway. Okay, so that will be a better choice. You can do it under topical, or you can do it after inhalation anesthesia with the child still breathing spontaneously. So the safest option for a anticipated difficult airway with a huge cervical meningocele will be fiber optic intubation under topical anesthesia or inhalation anesthesia technique. Okay, that is the answer that you have to give in the exam.
Yes, sir.
Right. So that is the first challenge in anesthesia, and all the drugs that you use, whether for inhalation infection or whether it's for intravenous infections, the analgesic opioids, the muscle relaxants, all the drugs that you use, you have to use them in the correct titrated doses, because the enzyme systems, the hepatic and renal functions are all very, very premature in these children, not fully developed. So any error in dosage will cause overdosing and the child will not be able to recover from that. So adequate calculation should be done, and all the drugs have to be very well diluted to give the exact dose, because their body weight will be only about maximum 3 to 3.5 kgs. Okay, because the neonate range from anywhere between 2.5 to 3.5 kg maximum. So the drugs have to be properly diluted and the correct dosage has to be administered. That is number one. And then you have to keep the ambience of the theater at a higher temperature so that they don't become hypothermic. And all measures to keep the baby warm, like your warming blanket should be kept on the before placing the child. The ambient theater light should be there to keep the body temperature of the child at a normal level. And any intravenous fluids that you give should be warmed and infused. So they become hypothermic. Okay, so these are the other precautions that you have to take. And blood loss should be correctly assessed. And you must replace the blood loss by giving the matched and the cross-matched and the compatible blood to the child. And as you rightly said, some children born with this problem are having also have a tendency to develop what is called latex allergy. So you mentioned that in your answer. What do you understand by the latex allergy? What is the treatment for that? What is the prevention that you will do? How do you treat that latex allergy? If at all
Like latex-free gloves and all.
So what is latex actually? Latex is a rubber, isn't it?
Yes, sir.
The gloves that they normally use earlier days, they're all made up of rubber. And that contains a chemical called latex.
It is.
And the latex allergy was found out in the late 80s. They found that patients who were touched with a gloved hand, they immediately developed some sort of immediate allergic reaction in the form of severe anaphylaxis with mucosal edema, bronchospasm, and hypotension. All the classical features of anaphylaxis were noticed in patients who had otherwise been behaving normally. So they found out a condition called latex allergy, and that can happen to the person using the rubber or to the patient also. So some of the medical personnel, doctors, they will say they have latex allergy, but that will be a milder form of skin uh, irritation and eczematous like changes in the skin happening, which is a milder form, but it can be an acute anaphylaxis also. So better to avoid all latex containing products, not only in the form of gloves, but what other gadgets that you use also can have latex.
Catheter,
Urinary catheters, intravenous catheters, all these things can have latex composition. So you have to avoid these things. And the third important challenge is the positioning. This surgery is mostly done in the prone position. So what are the precautions you have to take? You mentioned about the pressure points. Protection of the eye is very important, and adequate respiratory movement should be facilitated by preventing squinting of the diaphragm. So the child should be supported well on the upper part of the chest, not on the abdomen. Okay, and the pelvis should be supported so that you can have a free movement of the diaphragm to facilitate the good ventilation. Otherwise, the child may have collapse of the lower parts of the lung and go in for atelectasis, which may cause desaturation intraoperatively, as well as it may cause hypoxemia in the postoperative period also. And secretions will be retained, and that will lead to postoperative respiratory complications. So this prone positioning is also a very important challenge which has to be taken care of. And then intraoperatively, adequate pain control can be given by either the drugs that you mentioned, fentanyl or remifentanil. What about paracetamol?
suppositories can be paracetamol suppositories.
Suppositories can be kept for pediatric patients. So that also is another way of managing the pain. And after because this something like a hernia repair, so you push back the contents and then suture the dura and the skin over that, and or sometimes they may keep a mesh also and try to close the defect so that it doesn't bulge again. And so there is no need. The majority of the time, the child may not require any elective postoperative ventilation. Okay, and so the child can be reversed, and post-op positioning is also very important. As you rightly mentioned, you can't allow the baby to lie on the back for at least 3 to 4 days till the wound settles. Otherwise, the chance of wound dehiscence will be there. And so the child has to be taken care of in the lateral positions or in the prone position itself in the post-op period also. And another important pre-op thing that we have to mention is about the hydrocephalus. Sometimes the children with meningocele, whether it is lumbar, cervical, or sacral, sometimes they may have a hydrocephalus also. The CSF flow may not happen normally. So if they have features of raised intracranial pressure, that also has to be taken into consideration. So, but usually it will not be very severe in these children. Why? Why? Even though the pressures can rise, but it will not be very alarmingly high. Why? Is the skull compliant or very rigid in a newborn?
Compliant.
It's a very soft skull. The sutures are all not completely fused. Up to the age of 18 months, children have the capacity to expand their skull volume. The sutures can separate and the fontanelles can enlarge and the pressure can get accommodated in the skull. So even if there is a rise in intracranial pressure, it will not be alarmingly high like an adult where they have a rigid skull. But this will be an important point that you have to take care of, and that also has to be ruled out. How will you assess the degree of hydrocephalus pressure? Right? What clinical examination will help you to identify the presence of hydrocephalus?
Circumference.
Its circumference, very good. Okay. What is the normal head circumference?
33.
35 to 38 centimeters. Okay, that is the normal head circumference of a newborn. But if the child intrauterine itself, it has developed hydrocephalus, it may be born with a head circumference of 40 or 45. Okay, up to 40 to 45, it will indicate. But in case there is an adaptive function and the pressure is not that high to expand the skull, the head circumference is normal, but still if there is a suspicion there is a hydrocephalus, what are all the other gadgets that you can use to find out whether there is a increased intracranial pressure or not?
Bulging fontanelle.
Bulging fontanelles, very good. Okay, without the head circumference increasing, fontanelles will bulge out and it will also be palpable, palpating. That is, it will be throbbing. Very good. Next.
The veins will be dilated.
Veins will be dilated over the scalp. Very good.
Downward gaze of eyes.
Huh?
Downward gaze of eyes.
I'm not able to hear it.
Sunsetting sign.
Sunsetting sign.
Sunsetting sign, if it is happening, it would be so huge. Sunsetting sign is a very late sign. That in that case, the head will be almost, you can diagnose it just at the look of the baby. My question is, if the head circumference is normal, as somebody said, the fontanelles will bulge out, number correctly. The scalp veins also may become dilated. Can you use some gadgets to find out whether the pressure is increased or not? Neuroanesthesia, this is one of the important questions. Ultrasound use, nowadays everything is done with ultrasound. Can you do any measurement of something, some anatomical structure using ultrasound? What is the eye connected? How is the eye connected to the brain?
The papilledema.
Papilledema can be diagnosed, but in a child to look for papilledema is very difficult. But ultrasound you don't use.
Optic nerve.
Optic nerve diameter.
Optic nerve diameter, excellent. That is the latest thing that we now depend on. Okay, optic nerve diameter study using ultrasound will also help you to identify the presence of raised intracranial pressure. Okay, so that is the one thing that has to be ruled out before you take up, or you have to, if it is present, you have to prevent, take steps to prevent rise in further intracranial pressure, which, as I said, the most important danger is coning. The brain stem will get entrapped in the foramen magnum and the sudden respiratory arrest can happen. Will there be any clinical signs if there are evidences of raised intracranial pressure? And what is that triad of symptoms called?
Cushing response.
Cushing's reflex or Cushing's syndrome. Okay, what is that Cushing's response to raised intracranial pressure? What are all the things that will happen?
There will be hypertension and bradycardia.
Hypertension and bradycardia. Okay, in the neonate, you expect the heart rate to be more than 100. But if the child has got a normal heart rate of 70 and 80 like an adult, then you have to suspect that the child is already having raised intracranial pressure, and there will be a increase in the compensatory increase in the blood pressure. So there will be hypertension and bradycardia, and the respiratory irregularity also will be there. So if these three things are present, you can even clinically diagnose the presence of Cushing's triad, which is an indicator of raised intracranial pressure. So these are all the questions that you can expect in your Viva exam if the case is given. So that also you have to keep in mind. So otherwise, you have made a very beautiful presentation. And, only thing you can cut down on the initial process of etiology of this development of. In case you want to write this as a total answer for theory questions, you can prune that the initial portion of
Yes, sir.
elaborate description of how the meningocele develops and what are all the causative factors. All that can be edited so that you can have time to complete your answer. Right from your first class, this batch being the next theory exam going batch, I want to remind from the beginning. In your theory exam, to get through your exams, you have to develop the skill of writing the answer within the available time. That is
Yes.
very, very important so that you can attend all the questions. So right from now, you must start training yourself to complete
Yes,
the answers for each and every question. They usually give about 10 questions in 3 hours. So
Yes.
180 minutes, you have 10 questions, so you will have only 18 minutes for a question. So you must practice in such a way that you will be able to complete the answers within that 18 minutes so that you can have some time to revise and correct any mistake that you have made at the end also. Okay, so that is the way you should train yourself to get through your exam in theory. So I'll just share